Alzheimer's disease and Huntington's disease. There is already discussion of one neurodegenerative disorder, namely, what is the neurodegenerative disorder already discussed? Huh? Parkinson's. In Parkinson's, what are the drugs primarily? Levodopa, carbidopa, pramiprazole, huh? Jore, louder. Primarily, one is dopamine agonist and another one is anticholinergic, centrally acting anticholinergic. Now, another MCQ, that which drug to be used in drug-induced Parkinsonism? Benjexol. It is which group of drug it is? Centrally acting anticholinergic. Why it is preferred? Explain why. Why it is preferred? Which drug can causes Parkinson's-like disease? Like? Haloperidol. Haloperidol group, they can cause it, and haloperidol used in psychosis, schizophrenia. They can cause Parkinsonism. In this drug-induced Parkinsonism, drug of choice is centrally acting anticholinergic like benzoxol. Clear? Why? Explain why. Because if we increase dopamine in the CNS, what happens? It is already blocked by the D2 receptor blocker like haloperidol. So we have to reduce the cholinergic action by giving some centrally acting anticholinergic. So why there is Parkinsonism? There is a disbalance between dopamine and cholinergic system in the CNS. In case of Parkinsonism, which one is taken overhanded? Decreased dopamine. That means relatively increase of acetylcholine. So either we have to supplement some dopamine or we have to counteract that anticholinergic action by some giving anticholinergic. If the dopamine receptors are already blocked, if we give dopamine, which is even present in the CNS, is it helpful? Because already blocked, it is blocked by haloperidol or antipsychotic. So we have to take the other way, reduce the cholinergic activity by giving some centrally acting anticholinergic. Clear? Now today we will discuss about Alzheimer's disease. Alzheimer's disease, it is a progressive neurodegenerative disorder where the two main thing is A beta plaque or NFT, neurofibrillary tangle. It is in the tau tangle, that is NFT, and an amyloid beta plaque. These are two pathognomonic features of Alzheimer's disease, and it present with primarily loss of memory. And here cholinergic transmitter, cholinergic system is in the brain during the early stage, it is effect and it progress. The main thing is cholinergic system. So if we go for the symptom, three main symptom is cognition, daily functional, and there is some neuropsychiatric problem. Cognition means memory loss, loss of temporal and spatial orientation. There is loss of or disturbance of the language. These are all come under the cognition. Then daily life like personal hygiene, dressing, handling money, these are also বলো কি বলছো বলো also কি বলছিলে Eh? Bola? Agnosia. The loss of, then it is neuropsychiatric. Neuropsychiatric means there may be mood disturbance. Mood disturbance means what are the two? One is depression, one and another one is bipolar. In bipolar disorder, manic disorder. So it is the two thing. One thing is, one pole is the depression, severe depression, and another pole is mania. So we prefer which drug in mania? Lithium. Lithium for acute use. Anything else can be used? Is there any other drugs that can be used in mania? Bolo. SSRI antidepressant primarily. আর কি ড্রাগ? লিথিয়াম ছাড়া কোনো ড্রাগ ইউজ করা হয়? হ্যাঁ, benzodiazepine, carbamazepine, it is used. Carbamazepine, valproate, all these drugs, though primary use is carbamazepine কোথায় ইউজ হয়? valproate কোথায় ইউজ হয়? Anti-epileptic, but it has a used in chronic type of, to prevent the relapse, that can be used. So these are the cognition. The main problem with the Alzheimer's disease is memory loss. But other than memory loss, there is reduced daily activities, as well as there is some neuropsychiatric disorders like mood disturbance, agitation, aggression. These are all included in ADs. So there are three types of management. One is symptomatic, next one is disease modifying, and regenerative. Regenerative, what is regenerative? যে নিউরন গুলো destroy হচ্ছে তাকে regeneration. Those are very advanced cases, but not used in our third world countries. In our countries, the primary treatment and only treatment is symptomatic, not even disease modifying. So there are three type of management. One is symptomatic, one is disease modifying, and regenerative. For our purpose, we restrict our treatment, we have to restrict our treatment within the symptomatic only. There is no role of regenerative or disease modifying in our setup. So for current approach of the Alzheimer's disease, it is one part is pharmacological, another part is psychological, and other one is caregiving. So not only the pharmacological aspect, but there is another is the psychological. Some antipsychotic can be given, but all these are symptomatic. And last one is caregiver. How to give this care to this patient who lost his memory and not able to do their daily activity. Pharmacological treatment of Alzheimer's. The short note, it comes as a short note, or a few times you have to ask in Viva what are the drugs used in Alzheimer's disease. So our target, if you see that two treatment guidelines, one is if it is not treated, what happens? It is like a sigmoid curve. So it doesn't delay, the symptomatic treatment doesn't delay the worst possible position, but it can, in middle phase, it can have a very successful treatment, can give a better life to the patient. So main treatment is cholinesterase inhibitor. So if we go for the pharmacological point of view, what is the main problem? The destruction of cholinergic neurons. So loss of cholinergic activity. How we can counteract that? How we can counteract the reducing cholinergic activity? By inhibiting destruction. By inhibiting destruction. By which enzyme acetylcholine destroyed? Acetylcholinesterase. So if we inhibit that enzyme, that is acetylcholinesterase, namely FDA approved acetylcholinesterase inhibitors in mild, moderate and severe type of Alzheimer's disease are already anticholinergic পড়ানো হয়নি কি drug anticholinesterase inhibitor where it is used. These are donazepam, rivastigmine and galantamine. Donazepam, rivastigmine and galantamine, it is used to improve mild, moderate as well as severe type of Alzheimer's disease. Another type of is NMDA receptor antagonist. NMDA receptor antagonist also helpful for management of neurodegenerative disorders like ADs. The main management is acetylcholinesterase inhibitor, namely donazepam, rivastigmine, galantamine. Whereas another NMDA receptor antagonist is also helpful, namely mementamine. Mementamine is also helpful in treatment of Alzheimer's disease. The management or treatment of pharmacological agents used in Alzheimer's disease can be classified under two groups. Kiki? Acetylcholinesterase inhibitors, namely kiki? Donazepam, rivastigmine, galantamine. Whereas another group of drugs, NMDA receptor antagonist, named mementamine. Now, pathological, how it acts? Galantamine, rivastigmine, donazepam, কিভাবে কাজ করে? কি করে? They inhibit breakdown of acetylcholine, where? In the CNS. And by inhibiting that, they increase the concentration of acetylcholine in the CNS that can counteract the pathology of ADs, Alzheimer's disease, that is degenerative or loss of acetylcholine cholinergic neuron in the CNS. এটা লেখা যাবে তো? Basically pharmacological management of Alzheimer's disease. কি হবে? দুটো গ্রুপ. One is acetylcholinesterase inhibitor, another one is NMDA receptor antagonist. NMDA receptor antagonist is mementamine, whereas acetylcholinesterase inhibitors are donazepam, rivastigmine, galantamine. Even if when we give this symptomatic relief, we cannot regenerate the neuron, or we cannot modify the disease. So what happened? The shift is just parallel to it, but it cannot be reverse one. You have to understand all these drugs, it is only symptomatic relief. There is no role of regenerative or disease modifying agent used in case of Alzheimer's disease. For your perspective, drug management of Alzheimer's disease, one is acetylcholinesterase inhibitor, another one is NMDA receptor antagonist. Next one is Huntington's disease. You heard the name Huntington's disease? Huntington's chorea. What is chorea? Abnormal quasi-purposive movement. কোথায় হয়? Any other disease name? chorea, Sydenham's chorea, you heard the name Sydenham's chorea. Sydenham's chorea. Rheumatic fever, which organ involves in rheumatic fever? Heard the name rheumatic fever? Which organ involved? Which system involved primarily? Heart. Very good. So it is endocarditis, myocarditis, pericarditis or pancreatitis. What is the difference between these four? Endocarditis means inflammation of endometrium. Myocarditis, inflammation of. Pericarditis means, pancreatitis means whole. So in rheumatic fever, which age group is involved? Which age group is involved in rheumatic fever? Which age group? Children, pediatric age group. Which drug to be given? Rheumatic fever? Aspirin. What are the different doses of aspirin? Different doses. Aspirin. Aspirin complete na? Aspirin পড়ানো হয়নি? কোন গ্রুপের ড্রাগ অ্যাসপিরিন? NSAID. Aspirin, they have 3 different dosage regime. One is low dose aspirin, 75 to 350. That is acts as a antiplatelet. Then 1 to 2 gram, that acts as a antipyretic analgesic. And if it is more than 3 gram to 5 gram, it is acts as a anti-inflammatory. So the example of use of aspirin as an anti-inflammatory is কোথায় use হয় anti-inflammatory? Clinical situation, rheumatic fever. Rheumatic fever is an example of use of highest dose of aspirin. তাহলে rheumatic fever কোন organ involve করে primarily? Heart, pancreatitis. Then which drug to be given? Aspirin along with steroids. Steroids also has some anti-inflammatory property. Next, what is the consequence of this? Why it is important for your purpose? What is the consequence of rheumatic fever? All these mitral regurgitation, mitral stenosis, most of these are primarily due to the consequence of rheumatic fever. So if you have a patient having some valvular regurgitation or stenosis, you must have take a history of any fever, rheumatic fever. সেখানে কিভাবে জিজ্ঞাসা করতে হবে? How you can, it is long standing fever involving in heart and you having a high volume of aspirin for long duration. So why it is important? Why it is important? So in that case, how we can diagnose rheumatic fever? In that situation, there are some major criteria, some minor criteria. In major criteria, one is Sydenham's chorea. Sydenham's chorea is another type of chorea. In Huntington's, there is chorea also that is called Huntington's chorea. But chorea is a abnormal quasi-pervasive movement, abnormal movement that can be having due to the neurodegenerative disorder in adulthood. It can have a due to the rheumatic fever. এতক্ষণ পর্যন্ত কি কেন বললাম why we are going to the rheumatic fever? Chorea, it is a abnormal quasi-pervasive movement of arms, especially in arms. So why it is important? In Huntington's chorea, they have a feature of chorea. In case of rheumatic fever, they may have a symptom, have a chorea, abnormal quasi-pervasive upper limb movement. Now come back to the Huntington's chorea. It is a autosomal dominant type of. Next one came as a MCQ, not for pharmacology, but when in need, it has a CAG trinucleotide repeat. So CAG means ki C mane নিউক্লিওটাইড গুলো কি কি আছে? A, G. So these CAG repeat is seen in case of autosomal dominant Huntington's disease. Clear? তাহলে Huntington's disease এ কি হয়? একটা abnormal movement হয়, সেজন্য chorea is also present in the another disease in the childhood, that is called rheumatic fever. Now you have to remember that it is a primarily autosomal dominant, and when it is a primary autosomal dominant, there is a CAG nucleotide repeat, and chromosome is chromosome 4. You have to remember these three things not for pharmacology but for the NEET. Huntington's disease, CAG nucleotide repeat, and chromosome 4, and it is a autosomal dominant. Three things: primarily autosomal dominant, CAG repeat, and chromosomal 4. Progressive chorea and dementia. So it also has a dementia. Alzheimer's disease কি থাকে? Alzheimer's disease কি নিয়ে প্রেজেন্ট করবে? Loss of memory. Here also there is a dementia and progressive chorea, and it occurs in the adulthood. The chorea in adulthood goes in favor of Huntington's disease. Chorea in children goes in favor of rheumatic fever. So progressive chorea and dementia started in the adulthood, number one. Now there is an imbalance between dopamine, acetylcholine, and GABA. And where it is happened? Basal ganglia. So what happened in chorea results from functional overactivity of dopaminergic system in striatonigral pathway. Whereas Parkinsonism কি হবে? Parkinsonism কি হবে? ডোপামিনটা হাই হবে না অ্যাসিটাইলকোলিনটা হাই হবে? রিলেটিভলি ডোপামিনটা লো হবে। Where in Huntington's chorea the dopaminergic overactivity will be there. Dopaminergic overactivity produce this chorea. What is chorea? It is abnormal quasi-pervasive movement of upper limbs, and if it is occurred in the adulthood, it favors Huntington's disease. Go search for any dementia symptom. If it is in the childhood, in pediatric patient, we look for কি সিস্টেম করব? যদি চিলড্রেনদের হয় একটাই সিস্টেম, সেটা হচ্ছে হার্টে কি দেখবো আমরা? হ্যাঁ, সিভিএস হার্ট। কি দেখবো? গো ফর মারমার। Is there any murmur? What is murmur? Abnormal sound due to the cardiac activity. S1, S2, S3 বাইরে গিয়ে কিছু পেলে সেটা murmur. Clear? So in case of Huntington's disease, the dopaminergic system takes the overhand in striatonigral pathway. It is due to because of increased responsiveness of dopaminergic receptor or deficiency of neurotransmitter that normally antagonize the dopamine. তাহলে কি হতে পারে? একটা হচ্ছে ডোপামিনার্জিক অ্যাকশন বেশি, তার মানে রিসেপ্টরটা মাচ মোর সেন্সিটিভিটি, বা ডোপামিনকে যে কাউন্টারঅ্যাক্ট করে। কে কাউন্টারঅ্যাক্ট করে? সিএনএস এ, বেসাল গ্যাংলিয়া, স্ট্রাটোনাইগ্রাল পাথওয়ে, অ্যাসিটাইলকোলিন and GABA. That is their activity if there is a less activity. So drugs that can reduce the activity of dopamine in striatonigral pathway is helpful to control the chorea. Clear? তাহলে আমরা পার্কিনসনিজমে কি হয়েছিল? ডোপামিন কমেছিল, লেভোডোপা দিয়েছিলাম, আর সেন্ট্রালি অ্যাক্টিং অ্যান্টিকোলিনার্জিক দিয়েছিলাম। হেয়ার কি হচ্ছে? ডোপামিন বেশি হচ্ছে। তাহলে আমরা কি করব? আইদার ডোপামিন সিনথেসিস কমাবে বা রিসেপ্টর ব্লক করবে। ডোপামিনের অ্যাকশনটা যে কমাবে সে কোরিয়াকে কমাবে। সেটা কে? আইদার ড্রাগস লাইক ডিসারপিন, টেট্রাবেনজিন You heard the name reserpine. Reserpine ki kore? Reserpine, how it acts? They deplete the storage of neurotransmitter. So storage of dopamine is depleted, or the blocking the centrally acting some dopamine receptors like butyraphenol phenothiazines. Phenothiazine primarily used as a এগুলো কোন গ্রুপের ড্রাগ? ডোপামিন অ্যান্টাগনিস্ট কোথায় ইউজ হয়? হ্যাঁ, জোরে? Psychosis. So it is a antipsychotic drug. And haloperidol D2 antagonist. These are all. So D2 antagonist is helpful in Huntington's chorea, but it can produce drug-induced Parkinsonism. So two type of drugs, primarily dopaminergic neurotransmitter depletion by reserpine tetrabenzene, and if there is a centrally acting blockage of dopamine receptors like phenothiazines and butyrophenols like haloperidol. These are helpful in treatment. Here you have seen in normal cases from the striatal nigra, dopamine goes into the corpus striatum. But in case of Huntington's, what happened? This acetylcholine and GABA, this activity is less. So what happened? Who takes the upper hand? Dopamine. Dopamine takes the upper hand. In case of Parkinsonism, who takes the upper hand? Acetylcholine. Clear? So একটা হচ্ছে ডোপামিন কমানো, আরেকটা হচ্ছে কি গাবা বা অ্যাসিটাইলকোলিন যদি বাড়ানো যায়, তাই তো? So it has been seen that though it is theoretically there should be increase or helpful for counteract this chorea, but when we, in case of pharmacological action, even given that increased acetylcholine or increased GABA in striatonigral pathway doesn't clinically or therapeutically helpful. So for our purpose, for management of key disease, Huntington's disease, to control chorea, we prefer drug that either deplete the dopamine storage or counteract the dopamine receptor present in the striatonigral pathways, basal ganglia. So drugs which are helpful is either reserpine, how it acts or how it helpful in Huntington's chorea, mechanism of action bolle ki bola hobe, it depletes the dopamine storage in the CNS. By that they reduce the dopaminergic activity in striatonigral pathways. Here dose started with 0.25 milligram daily, go for the 7 days, then there is an increase of 0.25 milligram, and then the next week it is 0.50. Up to this it can go if the symptoms, up to which the symptoms is relieved or there will be production of some side effect. We can go up to that. It has been seen 2 to 5 milligram per day is effective enough. Clear? More than that, for your purpose, what are the drugs used in Huntington's chorea and mechanism, how it acts. Next one, tetrabenzene. Similarly, it orally 12.5 to 50 milligram thrice daily resembles the depletion of the storage of dopamine in the neural junctions. And phenothiazine and butyraphenol, how it acts? It blocks the dopamine receptors present in the striatonigral pathway or basal ganglia. By blocking that, the action, overactivity of dopamine will be counteract. So there will be reduction of the symptoms like chorea. Clear? তাহলে আজকের এ থেকে দুখানা জিনিস শর্ট অ্যাজ এ শর্ট নোট অর এমসিকিউ, ড্রাগ ইউজড ইন অ্যালজাইমার্স ডিজিজ কি কি হবে? দুটো গ্রুপ হবে, অ্যাসিটাইল কোলিনেস্টারেজ ইনহিবিটর, এইগুলোই কোলিনেস্টারেজ, নেমলি other hand NMDA receptor blockers mementamine. Whereas for Huntington's either dopamine storage receptor like reserpine tetrabenzene, whereas on the other hand D2 receptor blockers like antipsychotics like butanol and phenothiazine.
This area is infarction. Okay, this is infarction. This is the specimen of lung. Probably it is lung specimen. Now, it is the problem card. First question, identify the pathology in the given organs and define it. So, what is the pathology? Pathology is infarction. Okay. Pathology is infarction. Infarction is an area of ischemic necrosis. So what is ischemia? Ischemia means what? Blood supply obstruction of blood supply. So ischemia is the cause and infarction is the effect. Okay. Mention various causes: intravascular and extravascular. Intravascular cause, what are intravascular cause? Arterial and venous obstruction by thrombus or embolus. Obstruction. It may be arterial, it may be venous. And extravascular means compartment syndrome, means there is no problem in the vessel, but problem is outside the vessel, like any tumor mass. Any tumor mass obstruct the vessels from outside, not from inside. Okay? Now mention 4 factors which influence the particular pathology. Pathologies are anatomical pattern of arterial supply, means in some organ there are dual blood supply, and in some organ single blood supply, like lungs, dual blood supply, or liver has dual blood supply, and those organs supply with dual blood supply, they are less prone to infection. Okay? And organ like kidney, spleen, they are more prone to be infected because their supply is single vessel supply. If it is obstructed by any embolus or thrombus, so it will get infected. Okay? And vulnerability of tissue hypoxia and blood oxygen content and rapid development of infarct. Vulnerability means in some organ like neurons, our nerve tissue, they are very prone to infected. Like if the blood obstruction like 2 minutes or 4 minutes, then infection will occur and nerve will damage irreversibly. Okay, but muscle tissue like our heart muscle, myocardium, they are less prone. They can tolerate 20 to 30 minutes obstruction of blood flow. After that, they will irreversible change will come. Blood oxygen content, if hypoxemia occur, then infection will occur. And rapid development of infarct. What are its types? Two types. Red infarction, white infarction. Okay, two types. Okay. Shape in gross morphology, wedge-shaped with apex pointing towards the occluded artery and base forming the periphery of the organ. It is the morphological change in the organ. Okay. Now, what is this? 25-year female suffering from weight loss and cervical lymphadenopathy. So what is the picture? Can anyone tell me? Huh? Yes. Giant cell, yes. Giant cell is one of the components of this. But as a whole, what is called? Granuloma. It is granuloma. So, what is your provisional, and below the picture is giant cell. Okay, below giant cell. What is your provisional diagnosis, and mention 2 points in its favor? Tuberculosis, caseating epithelioid granuloma, and Langerhans giant cell. In a granuloma, the single most important point is epithelioid cell. Epithelioid cell is the most important component in a granuloma. Apart from epithelioid cell, there will be present lymphocyte, caseous necrosis, giant cell, all will be there. But important is epithelioid cell. Okay? Mention the type of cell death. Caseous necrosis. Central caseous necrosis. Okay? Mention the names for other granulomatous disease. Crohn's, syphilis, cat's scratch, sarcoidosis. Okay. Mention the cells involved in granuloma formation. T lymphocyte and macrophage. These are the 2 most important cells in formation of granuloma. Okay. And in granuloma, in Crohn's or sarcoidosis, the granuloma is caseating or non-caseating. Here, the granuloma in sarcoidosis, non-caseating. In Crohn's also non-caseating. In TB, it is caseating. Okay. What is this? Brain. It is the autopsy picture of a brain. RTA means road traffic accident. After road traffic accident, fracture femur occurred of a 14-year male and fatal convulsion. It is the brain. So, what is your impression? Tell me, what is your impression by looking this brain? It is the fat embolism. Okay? It is the fat embolism. What are the various clinical manifestations? The manifestations are pulmonary symptoms like dyspnea, tachypnea, neurological symptoms like consciousness, loss of consciousness, and cerebral edema, and peritoneal hemorrhage. Okay? In brain, we are seeing this is the peritoneal hemorrhage on the brain. What is its pathogenesis? How this is occurred? Okay, how this is occurring? Fat microglobules enter in the circulation and it convert fatty acid into fatty acid and damage the vascular endothelium, resulting in formation of platelet thrombi. These are nothing but the thrombus formation by platelet. Actually, it is thrombus formation. This. Okay. Like this. Mention once came to demonstrate the positive agent. Sudan black and oil red O. These are the Skane's name, by which we can scale the fat. Now, what is this? Can anyone tell? Apoptosis. তোমার class হয়ে গেছে, এগুলো? Your class, okay. Then you can answer me. Then you will answer, okay? So it is the apoptosis. Now, can anyone tell me the definition of apoptosis or apoptosis? What? Program cell death, that is a very simplified definition, okay? That is also good. It is not simplified definition, but definition what? Casper's dependent. Casper's dependent, yes. Casper's dependent program cell death. Mention two genes opposite. Can anyone tell me what are the genes? Very good, very good, very good. BCL2, MCL1, and BCLX. BCL2, BCLX, and MCL1 also. MCL1. Okay. Mention the morphological changes in cell during this process. Can anyone tell? What are the morphological changes? What? Fragmentation. First is cytoplasmic webbing, then fragmentation, and pycnosis, karyohexis. Nuclear pycnosis, karyohexis, and apoptotic bodies. Okay? Yes. Okay. So, you all know how apoptosis occur in our body. You all know. You have conception regarding apoptosis or apoptosis. You have conception like intrinsic pathway, extrinsic pathway. You all know. Microbiological pathway. Then, can anyone volunteer? You all know. আমি জানো তো তোমরা ব্যাপারগুলো নাহলে বুঝতে পারবো না। There are two pathways, microbiological pathway, which is also called intrinsic pathway, and there are also extrinsic pathway. Two pathways. Intrinsic pathway starts from mitochondria. From mitochondria FF1 and cytochrome C, these two secrete, and with the help of pro-apoptotic factor. What are the pro-apoptotic factors? There are some pro-apoptotic factors in our body. Okay, then with the help of that pro-apoptotic factors and initiators, like BIM, PUMA, there are some factors. Okay, so with the help of this, apoptosis occur, and after that, Casper's enzyme, with the help of Casper's enzyme, extrinsic factor start, and with factor 8, it ends. Ultimately, apoptosis occur. Okay. Now you tell me. Now you tell me types. There are two types of apoptosis, physiologic and pathologic. So, can anyone tell me what is the physiologic process of apoptosis? First is embryogenesis. When embryogenesis starts, it starts with the apoptosis. Then, not only lymphocyte, self-destruction of the self-reactive lymphocyte. Otherwise, normal lymphocyte will not involve the apoptosis. So, formation? Digit. Single. Okay, embryogenesis. Embryogenesis হয়ে গেল. And then destruction of the self-reactive lymphocyte. After that, destruction of the neutrophil after an inflammatory process ends. And lymphocyte also, some immune complexes after ending of immune reaction, lymphocyte also get destructed. After immune response. Then loss of endometrium tissue shedding in the menstruation, in process of menstruation. Then follicular reserve, ovarian follicular reserve decrease after menopause. Okay. So these are all the physiologic process of apoptosis. Now pathologic. Can anyone tell me? Pathologic? Yes, viral infection. Yes. Viral infection. Which virus? Which virus? What? Human papillomavirus? HIV. HIV. Okay. HIV. And hepatitis. And it may cause by any other virus also. Okay. After that, cell destruction after anti-cancer drug and radiation, ray. And after that, by some chaperone, misfolded protein. If misfolded protein accumulate in our body, then what will happen? Then some disease is occurring, like Huntington disease, Parkinsonism. This all caused by chaperone or misfolded protein. So they are destroyed by apoptosis. And endoplasmic reticular stress, ER stress response. These are all of the pathologic process.